Well, thank you all for being here for the inaugural event of Spring's Innovation Engagement Series. We try to bring to you the people who are the decision makers, the people that are adding value to our corner of the economy. And if you look at the poster out front, you'll see, and here we don't have descriptions, but back there we have descriptions. And I have to say this year, I think we have a pretty extraordinary lineup. Generally, we've been very, people have treated this event very generously with both their time and their willingness to be participative. So we are very grateful. We don't pay anybody to come, just in case you were wondering. People do this because they value the engagement and they value being able to convey important information about their areas of expertise and commitment. So this morning I have the honor of introducing a friend and a colleague, Dr. Tony Coletta, one of the truly terrific people in the healthcare business. I say this because long before Tony was in this important role, we consulted on a couple of projects at Blue Cross. And when you're in a collegial relationship, a consulting relationship, it's a different relationship than like an mutual employee relationship. And you really get to find out who people are. And I have to say that Tony is a doctor's doctor, and he's a patient's doctor. And more than all of his other accomplishments, which are very, very substantial, and he'll talk to you about some of the things that he's working on today, more than anything, leads in medicine with his heart. And I think that matters so much, more now than ever. Tony has a very distinguished record as a surgeon, as an administrator from Holy Redeemer. Most importantly, he's an alumni of this institution. And you're going to hear a little bit from Tony in a moment about his own reflections. Dan, can you? Yeah, we'll get to that in a minute.
I'm Dr. Tony Coletta, Executive Vice President of Independence Health Group and President of Independence Blue Cross's Facilitated Health Networks here in the Philadelphia market. I'm really excited to come speak at Jeff. Well, first reason is it's my alma mater. 4 years as a medical student and a full 6 years in surgical training in general surgery and transplant surgery, so I spent 10 years there. My father graduated from Jeff. There's just a lot of both emotional, intellectual, and personal attachment to the institution. And, it's a really exciting time for Jeff. All kinds of innovative things are taking place under Steve Glasgow's leadership. So I'm excited to speak at the Jefferson Speaker Series. I'm going to talk about innovation and healthcare, and specifically how disruptive innovation, a specific type of innovation, can help solve the problems that healthcare faces in the United States today, as well as some of the more immediate issues right here in the Philadelphia market. So what is innovation to me? I guess I'm still trying to figure that out. Because, there's definitions of innovation and there's types of innovation. And sometimes I think of innovation, I try to think of, even for myself, as being so that cool, edgy, modern, brainstorming, changing the world kind of innovation. That's always fun. And actually, I think the reality of innovation, when you're actually trying to solve difficult problems, it's enormously difficult to actually innovate, especially in a highly uncertain world. So it's not easy, and it's not always as cool as people think it is. On the other hand, when you see innovation sort of come alive, where the results of innovative strategic approaches come alive, it's incredibly more exciting than just watching the same old thing. I think the only other thing I would say about innovation is what I've learned is what I think the term is collective genius. No one person innovates completely and well on their own. No one innovator can do that. It really takes a collective genius of people who understand problems from different perspectives and can bring all kinds of ideas to the table, sifting through them and determining what makes the most sense to move forward with, understanding that you might fail, is both critically important and also difficult, but part of the process.
Please join me in welcoming Dr. Tony Coletta, one of Jefferson's favorite sons.
Thank you, Donna. Is this projecting in the back okay? Because it's a room that's organized in such a way that I'll probably be moving as much rather than just stand behind the podium. And that was one of the kindest introductions I've ever had, you know, as a doctor's doctor, a patient's doctor, because that still is where my heart lies after 25 years in the operating room. So I'm going to take you through this concept of disruptive innovation and specifically talk about Independence's strategy in this marketplace as to how we are trying to create a patient-centric, physician-centric model. But I'm going to start with this Rockwell picture. It's on the wall of a company that we started called Tandem Health, which I was the CEO of and presently chairman of the board of. It's the first thing is the employees of that enterprise see every day when they walk in this picture of the family doctor sitting across from the child, family in the room, because at the end of the day, what we're trying to do with these new strategies are wholly. And one of the things I found when I came to Independence for the first time is the risk of that disconnect, and maybe someone actually manage the care of patients without that can potentially have on the doctor-patient relationship. And so a lot of this about today are actually driven around trying to sort of bring it back into the equation. With all the innovation, that even in terms of technology in healthcare, you know, how do you continue human-centered innovation around that interaction, which we consider to be so. A lot of the models we're going to talk about in terms of value-based care are actually physician-centric, and by therefore meant to be patient-centric. So it's an important reminder for all of us. This is not such a friendly reminder. This is, I give Oliver Wyman the credit for this. This is called the Healthcare Hassle Map. So this just sort of schematically shows you how fragmented and poorly coordinated healthcare is in the United States today. Huge, huge, complicated problem for patients, for hospitals, insurers, and there isn't any one fragmented, disconnected system. At the end of the day, who have the most to lose here are patient care systems, so fragmented and disconnected that they end up having the most to lose. This is part of the enormity of the problem here. We'll take it back up. Many of you probably already know this, but let's talk about the healthcare problem in the United States beyond just what's happening in Washington today to decide what the next regulation is that's going to be coming down the pike. What's the reality of our situation? Is that if you look at our economically developed peer countries, their flags across the top, and you compare it to the United States, the next closest per capita average expenditure in those countries across the top is about $6,300 per capita. The United States is over $10,000 per capita now. So there's a $4,000 per capita differential in what we spend for healthcare in the United States versus what's being spent in our next closest, you know, economically developed, organized peer country that has similar economic structures, similar social and judiciary structures. So these are not third world countries. These are countries that are considered our peers on many other levels. If you take the same analysis and you look at it across a series of metrics, this is not, you know, propaganda. This is coming out of the Commonwealth Society and the World Health Organization. You take a series of metrics around measuring quality, and they come in different shapes and sizes, but it's accepted by the World Health Organization that these are indeed quality metrics. We rank last, United States. So we're paying $4,000 per capita more than the next closest country. And when you look across these 11 or 12 metrics of equity, how, you know, access to care, health and chronic disease, infant mortality, there's a whole list of them. You rank them all up and you put weighting to them, we rank last. So we have a huge problem. And I want to come back at the end of the talk about the enormity of problems and the role of leadership when you face problems of this order of magnitude. And then, because I was born in South Philly, my grandmother owned the grocery store at like 15th and Tasker. So I always come back to like, yo, Philly, like that Rocky theme, like, yo, Philly, we got a problem. Philadelphia has actually a relatively specific problem in that we are one of the most expensive healthcare metropolitan services areas in the country. Reasons, but that's the way this shakes out. Now, people could say, well, why is that? Well, these are just some numbers to give you an idea of the density of the healthcare community in these 5 counties in terms of the healthcare industry in these 5 counties. So in the state of Pennsylvania, there's 35,000 doctors, give or take, on any given day, and 168 acute care hospitals. That's in the state. In our 5 counties, depending on how you count them, nearly half of the doctors in the state are in these 5 counties. And I can break these numbers down for you further and show you that of these doctors, the vast majority are specialists, much smaller component of primary care doctors if you define primary care as family practice and internal medicine. So ratios of probably, think of this around, say it's 12,000 specialists, no more at the very most of 1,500 family practice and internal medicine docs. So very heavily weighted, very densely populated specialist community in these 5 counties, and almost half of the doctors in the state are in these 5 counties. In addition to that, 3 highly respected, world-class academic medical centers with medical schools and research and philanthropy and all the other components that go with it within a stone's throw of one another. Easy driving distance from one another. So high density, and by nature of the institutions, high costs, because of and for many other reasons, but including, the mission, education, research, what the entities are trying to do. These tend to be high cost institutions within a couple miles of one another. Highly dense academic community. And then 44 acute care hospitals, again, on any given day, scattered around the rest of the 5 counties. So, just trying to give you an idea of the density of the healthcare that's being delivered, and you can extrapolate to the economic implications of that. So this is 2016. Again, this is a study by an outside consultant, independent study, not done just for independents, but publicly available. The admission, 80K admissions per 1,000 in the hospital, the commercial population in 2016 was the highest in these 5 counties than anywhere else in the country. So we put more people in hospital beds than anywhere else in the country. And if you look at the median, it's the national average is right around here. It's just around 55, 58. You think of New York or Chicago, Boston as being similarly constructed markets in terms of size and density of healthcare, and they're not near Philadelphia. They were number 1. And the same thing applies to the Medicare population in this marketplace. Medicare Advantage is a product that we provide so we can measure admissions per 1,000 of Medicare Advantage and still running over 300. National average in a highly managed Medicare Advantage market is probably 220, 230. So on the Medicare side and on the commercial side, as one metric of utilization, specifically in this market, we're at the peak. Problems we need to try and solve. So I'll try and switch gears now to the strategy that we have embarked upon over the last 2 years. It's actually premised on a concept called disruptive innovation, a book and theory proposed by Clayton Christensen from Harvard Business School. And just a personal note, I went back and got my MBA. Never thought I would be preparing for something like this, but in 2006, and I don't remember a lot about the MBA, but this was a theory, when I studied strategy, this was a theory that really struck me. Because this disruptive innovation, as described by Clayton Christensen in the original theories, has clear-cut examples of how incumbents can be disrupted when the dynamic is right. And so when I describe to you our facilitated health network strategy, I'm going to try and show you that it's many ways clearly aligned with some of the principles that lie inside disruptive innovation. So it's not something we just randomly came up with. Anybody who's interested, the book is called Innovators Prescription. This is where they took the concepts of disruptive innovation and applied it to healthcare in an Innovators Prescription. In a second, I'll talk about the three components that in this book, as I read it and I extrapolated, that they felt were the essential components of healthcare disruptive innovation. But to give you a high-level understanding of the concept, it's that what happens is these incumbents in industries continue to produce high-end materials and products for their most complicated high-end customers who have the biggest margins, where the greatest margins are. Think robotics and healthcare. You know, and they continue to focus, the incumbents focus on those things because that's where the margins are, and they lose sight of the fact that there's a much larger core customer base that has an even greater need that can be addressed at a much lower price. And so disruptive innovators come in and address that core market that the incumbents have sort of left behind and address it at a lower price point. Think of one of the examples is Wang Computers, which was building bigger and bigger computers for their high-end, expensive customers, and they lost sight of the fact that there was this whole population of people that wanted desktops at a lower price. And Dell came in and did that, and Wang is gone. Think in healthcare, high-end, expensive, specialist, hospital, acute care-driven technology incumbents, where there's just this whole population of patients who need basic primary care and preventive care that could be brought to them at a lower price point than what is paid for these much more higher, more complicated models. So that's the theory why the feeling is that healthcare is so ripe for disruption. And there are three components in Innovators Prescription that they espouse really to disrupt healthcare. A new business model, so no longer just fee-for-service. So data-driven analytics and exchange of the knowledge of what's taking place in a new business model is driving the right behaviors for them. And the third in the book is named Facilitated Networks. Facilitated Networks is not a name that we just made up out of the blue, Facilitated Health Networks. There's plenty of examples in business of facilitated networks. Insurance and other worlds are facilitated networks. These are networks that are not just passive provider networks that are out there waiting to be accessed. These are networks that are linked by data, communication, a common cause, a common effort. So they're more active. They're facilitated. Provide enhanced care at a lower cost, think of it that way, than they could if they were just. So the concept of facilitated health networks derived from Innovators Prescription. So I hope this is right. Otherwise, I'll probably lose my job. That's just an aside, okay. But anyway, that's where you get facilitated health networks. And there are three components to our strategy. We say engage, enable, and empower. The first is engage, which is the new business model. So that are these new contracts that we're applying to these new partnerships, which we're engaging in the partners, the providers who are coming to us and wanting to get this done under the premise that the old model's ripe for disruption. And then, so these are less emphasis on fee-for-service and, in fact, lowering the rate of rise and escalation of the cost of paying a unit price for what's being done, and the ability to replace some of that revenue, not necessarily all of it, with these new models of care, value-based models, based more on, as much as you can base them on outcomes as opposed to just doing things. Easier said than done. Very difficult to do. Can't be done without doctors deeply involved in the center of it. These value-based models, we'll talk about them in a second, are clinically engineered. The doctors have to come along with nurses and all the support staff and the people who do these things, and you put them together, say, for a bundle of care for a particular diagnosis, whether that be a hip replacement or a lung resection. the clinicians have to determine how these things can be built and engineered in such a way that you can provide the best outcomes at the right price. That can't be done without the direct involvement of the clinicians. So anyway, the second component is enable. So engage, enable, and that's technology. So as part of these new facilitated health network arrangements, when a health system and or doctor group commits to the model, as they commit to sharing both cost and quality accountability, we commit to much more robust interactive exchange of data between the health plan and the provider. So the idea is to take claims database and combine it with the electronic medical record database and create a much more robust view of the patient, 360-degree view of the patient. Now again, easier said than done, but you know, and I'll talk a little bit about my perspective on that piece of it at the end, but this is where we're trying to go, is in these new provider partnerships, enhancing their ability, enabling them to perform in what is clearly is seen as a difficult world, transitioning from just getting paid for what you do to increased payment for the outcomes of what's being done. Empower, so engage, enable, empower. And for us, this is care coordination. Think about these three elements creating this facility. And for us, it's getting out from behind the building, putting less emphasis on telephonic care management and more emphasis on taking skills inside the building, of which they're formidable at Independence, and pushing people further out into the community and closer to the points of care, so that it's not just telephonic engagement of a member, did you get your colonoscopy yet? It's more like data-driven capabilities brought to the doctor's offices. Here's your patients who haven't had colonoscopies. How together can we be sure that gets done? That's different than just calling a member with a reminder. So the intent is to do this, right? All that we can to start a process towards aim is patient and doctor in the center and creating around them connected through technology, facilitated health networks. Again, you know, may be compelling by PowerPoint, very difficult to do, not easy, and it's not going to happen overnight. That the disruptive innovation will happen at a lot of different levels, and as it's us that's actually helping to promote that innovation, whether it's others. Once it starts to gain traction, it'll start to accelerate. The changes will start to accelerate. So it's fee-for-service mindset and changing it to value-based care. Lots of controversy about this over the year. It's easier said than done on the value-based care side. You know, how do you actually measure outcomes and apply quality and measure it up against cost? And again, it's another area where I feel the clinicians need to be deeply involved. When I say clinicians, it's also broad. It's nurse practitioners, nurses, it's doctors. It's those who understand, you know, the clinical aspects of all these things. That has to be brought to the table in order for this movement to gain traction and be successful. Presently, this is, we say, Jefferson has signed a facilitated health network. Penn has signed one. We're in discussions with others, including physician groups, so it's not just necessarily hospital-centric strategy. Networks of physicians are actually beginning to aggregate to try and you know, function in this brave new world of engage, enable, and empower, at least from our standpoint. So there are changes. Providers have various degrees of readiness for this, and we are transforming our internal business model to try and make it happen, right? You're a health plan, and you're managing risk in a traditional way, and you're just paying fee for service. You get a claim, you pay it or deny it, pay it. It's different in a value-based world. We have to develop the actuarial capabilities and the infrastructure, operational infrastructure, to deliver value and determine the financial components of that value and true up with the systems and the doctors and ensure that we're paying for what we contractually agreed upon. That takes a whole different component of infrastructure. So we're transforming our business model to allow that to happen because it's not like paying for fee-for-service anymore. I'm just going to talk a little bit about leadership. And my because I know there are medical students from the Physician Executive Leadership Group, if I have the name right here, and do I have it right? But I think, and you know, I know Steve Klatsko and Pete DeAngelo's here, and Ralph Muller, and other, and PJ Brennan, and Ann Dosimo, and physician leaders. This is going to take a huge effort on the part of the leaders in the region to get on board this transition, this patient centricity. And whether it's through just this strategy, Facilitated Health Network's IBC strategy, or whether it's through with other payers and through other components to drive towards defragmenting the system and a patient-centric, physician-driven enterprise is going to take a lot of strong leadership. So leadership's really important. And one of the things I've been sort of trying to force inside IBC's building that people need to think about is that we're living in an exponential world. Some of you may have started to read about exponential thinking. You may have read that been accumulated in the last 2 years than in the entire history of mankind. We all know the story of those of us when I was lined up for time to sit at the computer, and it was as big as, you know, and it had ticker tape things you had to feed into it, you know, those tape, and you know, now we all have it in our pocket. I mean, everybody knows it's just the beginning. This is the tip of the iceberg. This is the changes that are being in the world today are exponential. They're not just increasing linearly any longer. And one of the problems is the leaders who think linearly box themselves in. To be a real leader in this world, you have to think exponentially. You have to think that you're going to have to find a way to keep up with where the world is going. So it's not 1 on 1 makes 2 any longer. And it's not necessarily the limitation that one primary care doctor can only manage 2,000 patients. In an exponential world fueled by disruptive innovation, the vision is one primary care doctor could probably manage 10,000 patients. With the concept of disruptive innovation, technology, nurse practitioners, physician extenders, whatever it is, to risk stratifying the patient population so the most resources are directed towards the sickest, and you know, the additional resources are directed to keep the healthy well, but you stratifying the resources so that you're addressing where the greatest needs are. Lots of principles go into that thinking, but if you don't think that that's the case, if you don't accept that it's an exponential world and that indeed there's these limitations, I believe it's hard to be an effective leader in this kind of environment. The other story I like to tell is about Rocky Flats. Has anybody ever heard of Rocky Flats? You heard of it? Maybe you heard one of my prior. So Rocky Flats is a really interesting story. This is about in a positively deviant way. That sounds crazy, but it's actually meant to be a very positive attribute where organizations are thinking not just about making things good, but making them better than anybody ever envisioned, thinking way beyond just excellence. The story of Rocky Flats is an ideal story around that. Rocky Flats was actually a nuclear power facility that was put up right outside of Denver to build nuclear bombs in the late 1950s. And through the 60s, well, it was actually late 1940s, but through the 50s into the 60s, the need deteriorated, the plant deteriorated. It's northeast of Denver, right at the foot of the Rocky Mountains. Had on their hands a nuclear wasteland, truly a nuke smack at the foot of the Rocky Mountains. And everybody said, you know, 60 years and $30 billion to clean up. Nobody had ever done it before. Nobody had ever tried to do it before. Very problem. And not only was it cleaned up as a nuclear wasteland, it actually became a wildlife refuge. So they didn't just clean it up and shut the facilities down. It actually became a place where wildlife could roam. And the reason why we believe this why I believe it's such an important story is it was attributes of the leadership that it took to allow this to happen, maybe a tenth of what they thought it was going to cost. And I'm not going to, the lone wolf leader is a mistake, right? No one, and I think healthcare needs to understand that. Many of us sometimes propose ourselves as lone wolf leaders, or people look at us, this guy's going to lead us to the promised land. It doesn't happen that way. To become a wildlife refuge from being a nuclear with a lone wolf leader. It takes teams of leaders that bring to accomplish things like this. Aligning incentives that are meaningful. So, when you needed the employees of the wasteland to accept a retirement, you had to offer them economics that made a difference, right? Not enough so they go to a few extra. You had to offer them economics that allowed them to pay the rest of their kids to get them to move. So the economic incentives had to be different. They put up trees and bushes and flags to clean this place up. So immediately the message was like the rock, we're here for a purpose, for a reason. We're going to change this place. You made a difference. So, bless you. So the point is there's a great article and a great leadership story behind the transition of Rocky Flats. Now, I'm not saying healthcare in Philadelphia is similar to a nuclear wasteland. But I am saying that the order of magnitude of the problem, if you really step back and looked at it, you could think this is going to take forever. I don't know about you all, I don't have forever. For sure, I know I don't have forever, right? So could we do something distinctly full in a shorter period of time at a lower cost? And can we take the naysayers and the fact that we have the most impoverished inner city in the country, they're going to eat the next day, and we're wasting tens of millions of dollars, part of a wildlife refuge, as opposed to just, in the system. One more perspective, and then I'll stop and be glad to take questions, that drives me, and I tie it back to the enormity of the problem that I was describing at the beginning of the talk. So I, for one reason or another, found myself starting to do missionary work in Haiti in 2007. I got a phone call, would you be a general surgeon in a small clinic? For whatever reason, I jumped on it. I figured, I was at Bryn Mawr Hospital at the time. There wasn't much trauma out there, except when the maid shoots the butler or something like that, So I figured this is my opportunity to try something, to use my skill set in a way that maybe I never would have been able to. I didn't realize, though, that would lead to the day when I was at the Ritz-Carlton in California at a conference, and the worst disaster, worst human disaster in the 21st century hit Port-au-Prince, Haiti, while I was there. And I had already been working, this was 2010, I'd been working there for 3 years. I knew the people, I knew the missionaries, I knew Port-au-Prince. I knew 6 or 7 on the Richter scale earthquake would kill hundreds of thousands of people in seconds. You just knew it. Houses were built on top of one another without any code in the middle class. That's not even in the poorest region. So anyway, somehow, through divine intervention, I found my way flying to Haiti and driving into the quake, and ended up in the middle of this enormous human disaster. I don't know why the good Lord picked me, or whoever picked me to be there, but three days after it happened. And what I'm trying to describe in terms of what should drive a leader is that this kid, he's actually one great example of it. This little guy had a broken arm, and he sat in one of these chairs for at least 24 hours with a broken arm. We had a piece of tape on his head because we didn't have, that said X-ray left arm. And he finally got that arm X-rayed, and we put a cast on it. And the look and determination in his face, for me, this was an example of one patient at a time, right? We were only one of the 2 hospitals that were functioning in Port-au-Prince, and we were inundated with casualties, inundated, more than we could ever take care of. And one night we were making rounds, me and just one other doctor, the lights weren't working, and I kept saying that this guy had been in disasters before. I had never been in anything like this. I'm like, how are we going to possibly do this? How are we going to possibly get through this night? What are we going to do? It was just a sense of despair, and he kept looking at me saying, one patient at a time, one patient at a time. Just focus on the patient who's in front of you and move on to the next one. Because if you think about the enormity of the problem, you might as well just say, you know what, I'm packing up and going home. Or here, you might as well just say, I should probably just be playing golf. I'm not going to fix this. But I think all of us have to have the mentality that that's not the case, and we have to realize that everything that we do, at the end of the day, all of this is directed towards patient centricity. So everything, all the decisions that are being made now will one way or the other affect patients, and it'll affect them one way at a time, one patient at a time. And we can make enormous changes if we don't despair on the order of magnitude of the problem, and we function on a patient-centric model. So that's one of the learnings that I've been through that helped to drive the way I think about this and the way I hope that all of you will think about this as leaders. I'm done. So
So Dr. Coletta is going to stick around for a few questions, and I'll walk around with a microphone so everybody can hear your question. Who wants to?
Thank you, Dr. Coletta. I remember you as a second-year resident when I was first a nurse. So I am a nurse. I teach here in the College of Nursing, and I'm still back on your second slide where you were showing the other industrialized countries, and I can't help but think that in countries like France, when someone delivers a baby, this is like a low-cost intervention, right? They have nurses go out to the home like the next month to make sure that they're going to be there in early intervention before there's a problem. So in this big disruption, do you see a lot more of these types of lower price point types of interventions happening to really disrupt our healthcare and give us better interventions?
Absolutely.
At the point of where we need to be taking care of people?
I don't know if you can still hear me. I got warm, so I took the jacket off. But you know, the overall facilitated health network disruptive innovation I described at a high level, but I expect, and we're already seeing, a lot of clinical innovation happening at the point of care. I mean, independence, presently through Tandem Health and through an entity that helped build it, we now have over 1,000 house calls that are taking place in the Philadelphia market. Doctors and nurse practitioners going into the homes of the sickest of the sick and providing primary care. When they can, in concert, it's already happening. When they can, it's happening in concert with the primary care doctors. When you find out that these patients don't even have primary care doctors, this group of practitioners takes over their care because they can't. These are the sickest of the sick. These are people who can't always get up and go in to see the doctor, and so that's just one example of innovative models of care. We're aware of groups that are looking to do that, you know, for pediatric patients, you know, where they bring that special skill set to the point to the families. That's just one example of these are disruptive models. What we have to learn is that they're worth paying for at the end of the day, because if you're in a population health environment and you keep those people from, on average, so the sickest of the sick, I'll give you stats, in the Medicare population, the top 1% of sick patients, Medicare patients in this market, in the population of patients, are in the hospital on the average of 3 times a year. Okay, that's why our ADKs are so high. When you start targeted house call intervention, a brand new model in this marketplace, to bring the care to them, you can cut that in half within 6 months. They go down to 1.5 hospitalizations, maybe 1 hospitalization. They're dramatic opportunities. And those are just some of the examples. But our model has never been predicated. Our model is an acute care-based model. You don't get your intervention around anything, even palliative care and hospice care, until you're in the hospital. And moving the care out to the community is one of the major, I think, economic forces that are going to be at play, already are at play.
Back here, somebody put their hand up. Oh,
I probably won't need the mic, but it was very interesting. So I just want to say about this disruptive. I have a saying in class when I teach. I'm Mary Bouchot, and I teach in the School of Nursing, that what's new is old. I'm probably dating myself. I'm 21, I'd like you all to know. But based on that knowledge, when I was a little girl, and the first of 6 children, doctors and nurses did come to the home. Doctors would come and visit us, and I can remember that as a small child in my family. And of course, healthcare always was in the population. One of the sells of home care has always been, with home care visits, is we're cheaper. You don't have any, we reduce the rate of having these hospital-induced infections because you're surrounded by your own germs, in the own environment, surrounded by the people that you care and love. So I guess my concern is this isn't new. It may be disruptive, but we're going back to how we started in healthcare. This is where it was, and it has been. In the 90s, it was a very big thing because this is what was cost effective, keeping the people in the home, and we as home care nurses can tell you we've been keeping people safe and healthy and cost effectively because they weren't getting infections, surrounded by their own germs, in an environment that they, were used to and loved. And now we're just going back to something that we did my 21 years ago. So can you tell me how, is it just because we're repackaging it, or now we're finally realizing that that is how it was, cost effective, and now we see it is again?
So I would say that you're absolutely right, The house calls were done in the past. I even, when I started my surgical practice, was in the day where I did house calls when my primary care doctor asked me to, and actually made visits to nursing homes to care for patients there. What's different, what's fundamentally different here now is the business model. So we're not, at the provider end of this, we hope they will be less and less focused on how much you're going to pay me for the house call, because if you pay me this, I'll go there twice, and if I go, it's more along, just do it. And because you're managing now a population and you have a shared economic risk. So the business model is different. And the business model that caused house calls to change, stop paying for them. And so the business, the second thing that's different is technology. You talk about facilitated health networks. Mobile electronic medical records. So I've been on some of these house calls now because I'm one of these guys that got to see it for myself. And in fact, when I was at Holy Redeemer, hired the first house call practitioner brought into them. It was in New Jersey because they have a big home care business. When I did a house call visit with them, I'm like, this is like unbelievable. I mean, can't people see the natural value in this? He has his whole office in his trunk, and he was very adept at it. And he also practiced differently. He was not thinking the way an office-based doctor thinks when the patients come to him, He knew the family better, he knew the house, he knew the local pharmacist. I mean, I heard him talk and say, this is like a unique clinical skill set. Now it's beginning, that concept has got to be retaught. So that's on the care coordination side. But the ability to enact and execute on a mobile medical record that could follow the patient, and someone over here could access if they need to know something over there, is distinctly different. If you have to see the way these mobile workforces are deployed now to understand the full impact of the ability to have mobile data sharing around clinical components of the care. Dramatically different. So the business model and technology is clearly different.
Thanks so much for speaking to us, Dr. Coletta. So I'm a first year actually in the medical college, and I think it was great to hear a talk like this. A lot of students are really interested actually in getting involved in innovation. I was just wondering, what ways or methods would you recommend for students that want to get involved with disruptive innovation in their future careers? What sort of things do you think we should do?
Well, you have mechanisms here, right at Jeff to start. Right, so, and that involves, networking with like-minded. One thing I found about innovation, I've gone through this roller coaster on it, because any 1 minute I'm like, so, as I said in the video, it's so cool to be an innovator, but at the end of the day, actually deploying innovation in the business world is really difficult. So I would say local networking. Independence has a whole division around human-centered innovation, and we could connect you there and help you understand how a health plan looks at innovation. Multiple different levels, how to innovate on patient engagement platforms, and so it's just really all about, at your stage in the game, just networking and getting exposed to make sure it's something you really want to get involved in.
So I'm actually just going to make offer a commentary on physician executive leadership, who Dr. Coletta referenced earlier. So that's one of your medical student groups if you haven't gotten acquainted with those folks yet. Physician executive leadership actually started while I was here, and it's a very innovative, driven medical school group. I think, who here is from Pell? I know there are a couple of Pell kids here. There's like 160 members of Pell now, and a lot of the initiatives that are embedded in Pell are highly innovative. We could have a longer conversation about it, and I'd be happy to tell you more, but they know more about it because they're living it. So I would just mention that. And Dr. Coletta you spoke to Pell, I think, last year. Yeah.
Right, the physician executive leadership. I mean, there's embedded right in the university. In fact, I think if you're a medical student that wants to start to understand, what and where innovation may lie in the healthcare arena, you've come to the right place.
Yeah, we agree with that.
Hi, Dr. Coletta. Thanks so much. Really enjoyed your talk today. Just a question regarding, since we're moving to a value-based system, questions regarding those partnerships that IBX has forged with Jeff and with Penn. If you could speak to some of, potentially some of the barriers that you faced in getting decision makers to the table to understand what the way they need to change internally to get to a value-based system as a hospital.
Yeah, so the question is around what are the barriers to, in particular in our partnerships with Jefferson and Penn, in terms of implementing value-based strategies and actually making them come alive. I mean, the real barrier is the fact that I'll be honest, they look great on paper. In reality, when you're coming face to face with these large health systems that have, that are in transition, that have revenue that they need to try and continue to maintain, understandable, an older business model, how do you adapt these programs in such a way that you can address their needs during the transition? There's a whole debate in the country around provider readiness, and it comes in all different shapes and sizes. And I think the biggest challenge from a clinical perspective is how and when can you get the clinicians involved in a system? And if you're contracting on value-based through a system, and you have clinicians coming from different cultures, different medical staffs, different geographies, it's a real challenge to get them to the table to start to think about, yep, we can address the best component of a bundle for, a lung resection to be done at this facility by these doctors under these circumstances, where the bundle's been constructed, where the entity gains the most economic and the patient gains the most outcome-based priorities. It's really hard, and so we have to find a way to maintain certain aspects of the program that are not going to change, because you can't change the foundation for everybody, but be able to be adaptable in some of the things that you can be to address these varying degrees of provider readiness. It's going to be a journey for sure that we've just started.
Hi, Heather Rose, Jefferson Innovation Pillar. I feel like so much of this on one side is administrative, but I feel like on the other side there's a huge element of impasse in implementation in regards to the economics, because traditionally when we think of patients, we think of sick people. And this requires a shift to no longer thinking of patients, but thinking of communities and thinking about keeping them healthy versus waiting until they get sick and are patients. So really it's almost like we're trying to stop the flow in of that which we've, has been business as usual. Nobody has a bigger stake in it than the payers, other than the people themselves that are ultimately, hopefully, doing something preventative for the long term. I was just curious to get your sense on if we're economically prepared, or what we're doing to implement a way to be economically prepared for that major tectonic shift, I think.
Yeah, I think what you're talking about is the evolution of essentially population health. So we're no longer thinking of the business models predicated on the sickest of the sick. What the payer needs to do is build these attributed models of patients to a system in the deal and say, okay, in this particular scenario, here's your attributed patient population. Here are the cost and quality parameters associated with it. Let's figure out how we share in managing the cost and quality of that population. And what the providers need to do and are building the resources to do is to take that population, risk stratify it, ideally use EMR data and claims data to learn as much as you possibly can about the patients, even potentially bringing predictive analytics into who you think is going to become sick next month or the month after, although I feel like we really ought to try and decide who's sick today before we do all this predictive stuff. But the point is that it's all elements of approaching the entire population that you're taking care of, all the way from the sickest to those who remain well, and deploying resources across that spectrum. Now, the difficulty, we're seeing already in both Jefferson and Penn arrangements, is how does the provider and the payer extract enough value out of that to make it economically sound proposition, as opposed to just continue to put patients in hospital beds. That debate is ongoing as to how we can bridge that gap. It'll be different times for different systems. But I think everybody needs to be aware about the fact that it's inevitable that to one degree or another, this is going to come to play. Now, some people say, we're going to go back to fee-for-service. It's all going to go back to the way it used to be. Just forget it, this wave will go away. We don't believe that it will. And we believe it's unsustainable. So these are problems that we're going to have to figure out. There isn't any simple answer to it.
If I could just add one note, we have a little bit more time for questions. Anyone who is streaming in from our partner organizations across the enterprise, you can tweet your questions. Anthony will pick them up. The tweet information is up on the screen, so please feel free to tweet your questions. And in the meanwhile, we have a question back here from Terry Booker.
Great words, Dr. Coletta. I have a question for you. You've talked about your facilitated health networks, and you've talked about the Affordable Care Act and population health. So what are insurers and providers doing to pull the patient into population health? Because that part has to change as well. So how are you kind of pulling them into it as opposed to pushing it on to a patient?
So the question is around patient engagement and how they understand what's this value-based thing mean to them. So to me, there's one additional E, and we're just embarking upon this. We're going to presently using the physician practices as the first conduit. It's engage, enable, and empower, and educate them, the patients. I personally believe until we, as a healthcare delivery enterprise, including the health plans and the delivery system, commit to more transparency and empower the patients to see where they can really get the best care and why they can get the best care, engaging patients in this model is going to be extremely difficult. As long as we keep everything so close to the vest and we're not transparent about pricing and or outcomes, I'm talking about the entire spectrum of the way care is being delivered, truly engaging patients in this is going to be increasingly difficult. So, but that's the empowerment piece. You know, at the end of the day, they need to know, I have this problem, where should I go where I know I'm going to get the best outcome at the right price? And today they don't know that.
I think this is really a great opportunity for everyone, but if the goal is to have one doctor supervise 10,000 people, 10,000 patients, I think you said, how critical is it to get real tort reform in this country?
I mean, tort reform and all of the other elements that are in play, even especially in southeastern Pennsylvania. And I say one doctor to 10,000 patients, it was an example. And for me, sometimes I tend to be hyperbole, but let's say it's exponential. It's more than just 1 to 2,000. You know, addressing the problem of defensive medicine is at the heart of the equation, one of the hearts of the equation. In this market, which is a highly defensive medicine market, as you know, and those of us who practice here know, probably studies, although it's difficult to pin down, 8 to 10, maybe more % of the cost problem is related to just purely defensive medicine. So it's going to have to be a part of it. My issue presently, in terms of picking lanes about how we're trying to attack the problem, is look, there's defensive medicine, there's infant mortality, there's life expectancy, there are components of our cost-quality equation that are secondary to the way we to our political and socioeconomic infrastructure. A life expectancy in the United States is low on the list until you get to the age of 75, and then after 75 you live longer than most people in the rest of the world. But we're so low on life expectancy up to the age of 50, primarily driven by our lifestyles. You know, fast cars and guns and violence and drugs, where that's a component of our life expectancy that I can't tackle through this yet. The same thing goes to defensive medicine. It's, you know, it's clearly an issue, clearly a problem, and but at the present time, it's not something that we can tackle yet. Not to say that we won't be able to. You know, I look, if you establish over time stronger payer-provider partnerships, lots of important things could happen in the regulatory and governmental front. But it's a big problem. 8 to 10% of the costs that you saw could be easily tied into just defensive medicine in southeastern Pennsylvania.
So we have one tweet question. Anthony, can you read the question, please?
That might be Steve.
Yeah, I won't disclose their name. So can you expand a bit on your transition from practicing as a general surgeon to your role now?
Yeah, so the question is my transition. I mean, for me, I just hung up the scalpel one day. It was October 19th, 2009. Knowing that I could still work in Haiti, not knowing what it would eventually be, I knew I had to make sort of a clean break with the operating room. And I set 6 months out from being in the operating room after 25 years as my period of time to see whether I could survive in the business world. So I was very deliberate. I'm done. My last laparoscopic cholecystectomy, walk out of the operating room, I'm done. Everybody said I'd be back. I said, But then I had 6 months where I went to Holy Redeemer as a chief medical officer and executive vice president. On no better terms than any other executive in the system, I insisted that I be treated the way the other executives were in terms of, responsibility, roles, reporting, compensation, et cetera. And I gave myself 6 months, and if I fundamentally hated it, I could go back. My group would take me back. But at the 6 month juncture, I said, you know what? Actually, I kind of like this. Well, quick story I'll tell you, and then I am going to have to run too. But I have 25 years. I'm in private practice of general surgery. Private practice. So I'm, if I'm not working, I'm at Holy Redeemer. Maybe it's now right around Thanksgiving, and the human resource person knocks on my door and she goes, "Dr. Coletta, don't forget you have PTO." I'm like, "Well, what's that?" She goes, "PTO." I thought it was like the boat that Kennedy drove or something. She goes, "No, you have PTO." She goes, well, I said, "Well, what's that?" She goes, "Dr. Coletta, you have paid time off." I'm like, "What? What is?" She goes, "Yeah, you have 3 days of PTO, and if you don't take them, they don't roll into the." She said, "I have 3 days of paid time off?" She goes, "Yeah." I called honest, true story. I called my wife. I said, "Honey, I have PTO. I'll be home tomorrow." I didn't know what paid time off was, so there were elements of the transition that weren't so bad. Anyway, I appreciate your attention, and as always, it's great to be back at Jeff.
Before everyone leaves, if there are any students that have signed up for this course, the one credit course, please check in at the front desk before you leave so we can note your attendance today. So anyone who's signed up for the one credit course, please see the front desk. Thanks. We'll see you next week. Thanks for coming.